But I do want to make a few comments. First, that this is a wonderful way to celebrate International Women's Day. And I hope everybody knows that it's International Women's Day, and this is part of an extended celebration of the contributions of women to the Department of Psychiatry and to the medical school and more broadly to the profession. And frankly, I can't think of a better person to come and celebrate International Women's Day with us today. You'll hear more about Dr. Weissman in just a minute. Next week for Grand Rounds, Cyril D'Souza from our department is going to be talking about cannabis use disorder, in particular his work to try to understand the biology of cannabis tolerance and dependence and some novel pharmacologic approaches to cannabis use disorder that he'll be talking about. That should be very interesting. And the following week, that would be the 22nd of March, Tor Wager from the University of Colorado is going to come, and he's really a wonderful expert on the neural circuitry of pain, the difference between the emotional and sensory aspects of pain, the neural circuitry of that. So he's going to be talking about fMRI-based biomarkers for pain and emotion from models to interventions. I think that'll be a wonderful talk. He's a great speaker. Some of you may have noticed this week that the FDA approved esketamine, which is a new treatment for depression. And this is work that began here at Yale. And in the era that it was conducted, Yale was one of the few places that in the world that could have conducted a study like that. It's really an accomplishment for the department because it exemplifies the kind of collaborative environment that we have here, the kind of discourse and interchange that goes on every day in every part of the department. But it's a great example of how something that can start out as a kind of a basic science question can turn into a transformative treatment. And it's also a reminder that at the time that we did the ketamine study, people had the idea that all treatments for depression involved medications that you had to take every day, all medication treatments for depression, that is. You had to take those medications every day, and if you were lucky, after a few months, you will be feeling better. And the idea that a treatment could work overnight and that treatment might someday be broadly available and create new opportunities for people is just really inspiring and a reminder that the limitations in our knowledge and the limitations of our vision or hopes that sometimes are constraining progress. And it's often very important to think big, think bold, take some risks, think out of the box, and you never know where that's going to take you. So it's kind of an exciting day for all of us who were involved in the discovery of ketamine and for the department, which is really the home for this kind of innovation. So without further ado, I will introduce Dr. Carolyn Missouri, who is going to introduce our speaker today.
Yeah. So we're a team.
I want to check the stuff here.
Good morning. Welcome to the Grand Round, sponsored by the Division on Women's Behavioral Health Research in the Department of Psychiatry. I am Carolyn Missouri, as John said. As the director of the division, it's really my great pleasure to welcome everybody here from the department, as well as from other departments across the university. We're pleased to have all our colleagues here today. This is a particularly special Grand Rounds for several reasons, as you're going to hear in 1 second, and then you're going to hear by virtue of the presentation. The first reason that this is particularly special is because, as many of you know, this past year, the Yale School of Medicine recognized 100 years of excellence and achievements of women at the school. In conjunction with that celebration, the department launched a year-long celebration of women in psychiatry. This has been led and coordinated by Dr. Cindy Crusto, who's done a remarkable job, and the presentation today is part of that department celebration, and it's a recognition of, again, outstanding scientific contributions made by women. The second reason that this is a particularly special Grand Rounds relates to the mission of the Division of Women's Behavioral Health Research. And that is to bring investigators together to study the health of women, as well as to integrate the study of sex as a biological variable and sex and gender differences in mental health and addictive behavior research, in everything we do. The point is not for you to abandon what you're doing and become, quote unquote, a women's health researcher, but rather to mainstream the work of studying women and studying sex and gender differences and sex as a biological variable. And I've been doing this for 20 years, and I can say that there's really been a change in the environment over time. But in the last 2 years, there's a palpable change in which you're seeing so much more research emerge that points to the importance of this work. The division, as well as the Division on Addictions and Women's Health Research at Yale, which is the university's scientific home for advancing the study of women across a wide variety of medical disorders, have a close working relationship in these efforts. And I thank Stephanie O'Malley and other people for those collaborations. And then finally, the third reason this is a particularly special Grand Rounds is the speaker herself. We have the great pleasure of welcoming back to Yale a truly world-renowned researcher in the epidemiology, understanding, and treatment of depression, as well as the transmission of depression over generations. And so it's a pleasure to begin to introduce Dr. Weissman, who has refused to give me her entire CV because it's too long. Nonetheless, there are a few things that I absolutely have to say about her and draw to your attention. But clearly, within this period of time that we have, I can't adequately capture the wealth of her contribution. Nonetheless, Dr. Weissman, as you can see by this slide, is the Diane Goldman Kemper Family Professor of Epidemiology and Psychiatry. And she is also a very active epidemiologist and the chief of the Division of Translational Epidemiology at the New York State Psychiatric Institute. She received her PhD in epidemiology in 1974 here at Yale, and fortunately, she stayed here for some period of time. And it was until 1987 she was a professor of psychiatry and epidemiology at the medical school and director of the Depression Research Unit. And I think there are people peppered throughout the audience who remember the Depression Research Unit. I certainly do, where I had the pleasure and the privilege of collaborating with her when I was at the NIH years ago. And I was actually one of her first, if not the first, graduate student that worked with Myrna. Among her many honors, Dr. Weissman is a member of the National Academy of Medicine and an honorary member of the Royal College of Psychiatrists in the United Kingdom. She's been a visiting senior scholar at the Institute of Medicine, the National Academy of Sciences. She's been a consultant to many private as well as public agencies, including the WHO, Brain and Behavior, the American Foundation for Suicide Prevention. She's received the Distinguished Scholar Award from the Partnership for Gender-Specific Medicine at Columbia University. She's been acknowledged by the American College of Epidemiology as one of the 10 epidemiologists in the US who has had a major impact on public policy and public health. She's been recognized as a leader in the field for decades. In January of 2016, she was listed as one of the 100 highly cited authors in all fields by Google Scholar Citation. She has been the author or co-author of over 600 scientific articles and chapters in 12 books. And I will read the list of her 600 published articles now. No. One of my favorite papers, though, I have to tell you, is from 1977, Sex Differences in the Epidemiology of Depression, that she wrote with Dr. Clareman. This is my Bible for a long time, and I'm going to read you just one sentence from this. All aspects of women's roles are currently under scrutiny. Was she ahead of her time? I will let you decide. Among many other honors, she has published books and chapters, but along with her late husband, Dr. Gerald Clareman, who means so much to so many people here today, she developed interpersonal psychotherapy, IPT, an evidence-based treatment for depression and related disorders with over 100 clinical trials that are carried out worldwide, and you'll hear a little bit about that today. The current focus of her work is the study of the transmission of depression across generations, and she directs a 3-generation study of families at high and low risk for depression who have been studied clinically for up to 25 years and continue to participate in her studies where she does genetic and imaging work. She's also very focused on the detection of biomarkers for transmission and treatment response and the implementation of psychotherapy in low-income countries and populations, and studies on the effects of taking SRIs on the offspring of individuals who are taking those particular medications. But I'll conclude now with just saying that despite all these accolades and achievements, most notably to me, beyond the achievements and the contributions, is the quality of Dr. Weissman's work and the impact of her findings, as well as the strength of her commitment to informing our view of depression, a condition we all know is more prevalent in women than men, but also is one of the greatest causes of disability for women worldwide. So it's my great pleasure to introduce Myrna.
Thank you. That kind of an introduction can only make you very nervous. It can only be downhill after that. I am so happy to be here. I can't tell you how warm it feels inside. My late husband, Jerry Clareman, who died very young, he opened this place. And it was of the days of great movement for African Americans and for women. And there's just so many memories that come to my head when I come here and re-experience it again. And when I came to work here, I did not have a PhD in epidemiology. That only came afterwards. I just want to remind you that in 1964, the Civil Rights Act was passed, and it outlawed discrimination for race. That was what it was supposed to be. The opponents of this law thought that the way to really not have it pass is to add gender, and they did, and it passed. And I came here and graduated in 1974, so it wasn't that long after the passing of the legislation and all the things that happened in between. I won't tell you the stories about what it was like to be at Yale as a woman on the faculty. They're very humorous, and we had a lot of those last night over dinner and wine. I can say, though, Yale provided me with an extraordinary opportunity to do just about what I wanted to do and to try to get funding for it. And as long as I got funding, I could do it. And I met some wonderful people here. Carolyn, Missouri, was actually my first graduate student. And Bruce Ronsville was my first postdoctoral fellow. And he came to me, and I tell the story. He said he wanted to study violence in women. And Herb Kleber had just gotten me to be part of his grant on drug abuse and methadone maintenance. And I said to Bruce, well, you know, there's a lot of violence around drug abuse. Why don't you be a postdoc in drug abuse? And that's how he got started, and he had a spectacular career, and so did, of course, all the other people that were here. Jim Leckman was part of these studies. Carolyn was one of the interviewers. Don Cohen, of course, was great inspiration. And the department you have now under the leadership of John Crystal, I hope that you get some of those patents for ketamine, because if you don't, it would be very unfair, because this was really the place that pushed it and started it. So I'm not going to go into all the stories, because that would take my whole time, but I want to describe work that began at Yale, and also patients who we are still following from New Haven. They come to New York for their MRIs. And this is truly a Yale-New Haven woman's story. So my disclosures, they don't bring as much money as they should. And this is the team. And I won't go through everybody, but I want to make the point that to do this work, you really need a very diverse team. These are some more of them. And these are only the team that we have now. It does not talk about all the team members we had over the years. And this is the essence of my talk. I am not going to go into this because I want to tell you a story about our findings and where we've gone. But this is the model that we have in our research, which we call translational epidemiology, which is we go from population to bedside. We have people who have their careers made in mouse models who tried to use our samples to test out some of our ideas. We tried to go into the community and do interventions with some of the findings we have in studying families with depression. So this is what I consider the translational epidemiology model. And I'm going to talk about all these things, and I'm going to talk about it within the time limit, I hope. So let me tell you the context. When I started here, in the 1970s, the question was, does childhood depression exist? The conventional wisdom held that major depression was a disorder primarily of middle-aged and menopausal women and didn't happen in children. And there was a conference held at NIMH in 1978, and they concluded that the notion of a syndrome of childhood depression rests largely on surmise. Well, that was true. It was on surmise. There were no data. But the idea that it didn't occur in children or adolescents, we learned soon enough, was absurd. The first epidemiologic study of psychiatric disorders in the community was done in New Haven at Yale, the ECA, but it began actually with the Redlich survey of New Haven, in which he was looking at impairment. And we turned it into a small study using the SADS in one of the last waves of the impairment study that Redlich was doing, and that provided pilot data to show that you could really do an epidemiologic study of psychiatric disorders in the community. There was a lot of argument against that. They said you couldn't ask about psychiatric disorders in the community, and I said, Kinsey asked about sex. You don't think we could ask about psychiatric disorders? Fortunately, Jerry became head of Adamaha, and Califano said to him, well, how do you know the burden of mental illness? And Jerry used our 511 sample to show him that there was major depression in the community, and it was highly prevalent in New Haven. And that funded the ECA, and we applied like everybody else, and Jerry Myers was the principal investigator of the New Haven ECA study, which then went to 5 other sites. Everything else is history, because now we take for granted, and you take for granted in writing the DSM and all the things, introductions to your papers about the rates of different disorders in the community. In the 1970s, that data did not exist. But clearly what this showed is that depression begins young, and the biggest peak is somewhere between the ages of 15 and 25. So it really was not a disorder of menopausal women. It was a disorder that began in youth and young adolescents. It doesn't mean that people in their older years don't get depressed, but that's recurrence, it's not onset. So based on that, I started studying families. And I started with Generation 1. And I think Carolyn was one of the interviewers of Generation 1. And this is what we did. We began with Generation 1. These were people who came to CMHC, and who had moderate to serious depression. Most of them were ambulatory. We then chose the low-risk families from the ECA. So these were their normal neighbors. And they had to be normal, meant they had no psychiatric disorders on at least 3 interviews, because we had done a wave 2 on the ECA, and then we re-interviewed them again. We then followed all of their offspring that would agree, and these are all from New Haven, or the New Haven SMSA. And we did the same thing with the low-risk families, and the interviewers were all blind. We trained a bunch of interviewers to go out and do this. And as time went on, the second generation had children, and we had grandchildren. And I'm going to tell you the results of these studies. We now have about 20 generation 4. This is the major finding, and this has been a finding. This is the 30-year follow-up, and these are cumulative rates. And as you can see, there's over a 3-fold increased risk of major depression in the families, the generation 2 of the high-risk families. There was also 3-fold increased risk of anxiety disorders, almost the same as substance abuse, but that came later, though not significant. And we didn't find schizophrenia, and we didn't find bipolar. So this bred true. Now, I have to emphasize that the interviews with the high and low-risk families, the offspring, generation 2 or 3, were all done blind as to which family they came from. The interviewers were trained clinicians, usually social workers or master's levels in counseling, people we trained. They wrote big narrative summaries. In those days, we did those things. We don't do that anymore. And then the interviews with all the data were given blindly to a clinician who was a psychiatrist or a psychologist, and they made a best estimate diagnosis, so that we tried to keep ourselves as honest as possible. This just to show you some of the highlights. This is when the disorders began. It's the age-specific rates, and you can see the onset of the disorders in the high and the low-risk offspring is around the same age, somewhere, which is what we saw in the ECA. It begins somewhere around adolescence and peaks around age 15 to 25 to 30. And new onsets after that are uncommon. In fact, there is a whole study of depression in the elderly, with onsets in the elderly. If somebody over 60 has a first onset of depression, you begin to think about other kinds of reasons for the onset. In the low risk, we see the same pattern, although at much lower rates. And there's a little peak, and that may be premenopausal depression, but we don't really know. We don't have enough people there to make a statement. The sex differences are retained, whether it's a high or a low risk family. And you can see that there's always a big increase in the females versus the males. The females are the red, and the males are the green. And the females in the low risk families have quite high rates. This is one of the saddest findings. Remember, we know these people. They come to us, and they travel all the way to New York. We give them usually a weekend in New York. And the rates of deaths from unnatural causes, we say unnatural causes because sometimes you can't tell whether there's an opiate overdose, whether that was deliberate or not. So we've called everything unnatural causes, but we do have suicide notes in some. But you can see the high rate of death from unnatural causes, 3.9% in the high-risk sample, nothing in the low-risk sample. The natural cause deaths about the same in both groups, but look at the mean age of death. It's quite young. And these are the grandchildren. Fortunately, there isn't assortative mating in the second generation, so some of the rates get diluted in the grandchildren. And you can see the highest rates of depression are in the grandchildren where there's 2 previous generations affected, the 29%. And their average age, I think when we did this slide, was about 18. This is actually the group that, if one is doing biological studies, that one should focus on. And we're trying to do MRI studies on those. But people don't always agree to come if they're in the group we want. So let me just summarize the clinical findings. There's an enormous number of them, and these are, I think, the highlights. That the offspring of depressed parents, their average age when we did the last slides was about 48. I think they're about 52 now. They have increased rates of depression. The onset is usually in adolescence. It's usually almost always before age 40. They have more recurrences, impairment, divorces, treatment seeking, and increased mortality from unnatural causes. So although we don't know the genes for this disorder, we don't even know all the environmental effects. We can say that if you have an offspring who has a depressed parent, that requires some clinical concern. The grandchildren, only those who had 2 previous generations, had the threefold increased risk of depression. However, this group is showing an increased risk of suicidal behavior. So again, clinically, I think that provides a guideline. So what else have we learned? And I've just taken some of the highlights that people might find interesting. The first is, what do the adults know about their children? Now, the pediatricians in New Haven were a very socially minded group, and they were very happy mostly to participate in our studies. So we did, with permission, surveys of the pediatricians of the children, that's G2, in our study. And we asked them about what they saw as the psychiatric and behavioral problems of the children. And we found that they were largely unaware of them. And remember, we had done interviews directly with the kids. We had interviewed the mothers about the kids. So we felt somewhat confident about what we found, but most of them were largely unaware, or at least it wasn't in any records that they recalled, and they were very cooperative. But we didn't think that the mothers knew so much either. And we found that about 7% of the children or their mothers reported that a child had made a suicide attempt, but 60% of those mothers of the children who reported attempts, the mothers had not reported. Now, maybe they just didn't want to tell us about it, but it certainly, when we interviewed them, and we did very detailed SADS interviews, and we interviewed about suicide and suicide attempts, the mothers did not know. This study was done by a young resident, Walker, who died of AIDS. In fact, 2 residents who I supervised died of AIDS. I didn't even know they were gay because people didn't talk about those things in those days, how unfortunate it was. Parental bonding, that's a great instrument. Gordon Parker, who invented it from Australia, came one day and said he was doing a sabbatical with us. He's the first person who ever wanted to do a sabbatical with me. I didn't quite know what you did with him, but he came and he did his work for 6 months with us, and he was writing papers on parental bonding. And that's how we got parental bonding in our studies. We thought it was a great instrument because it measured something about the mother's perception of what she was like as a mother and the child's perception of what the mothering was like. That is, if the child was over about age 8. We didn't ask 6 and 7-year-olds. So we found that parental bonding was transmitted from mothers to daughters independent of maternal or daughter's depression, temperament, or socioeconomic status. They reported about the same thing. And we found that these parental bonding was remarkably stable over 20 years. When we went back 20 years later, we got pretty much the same results when we interviewed the mothers and the children. So it means it's a pretty good measure, and we've used it in all of our studies since then. Now, adversity, there's a lot of interest in adversity. People who are doing biological studies now want to have adversity in their studies because they realize that that has a big impact. We know that from animal model studies, and we know it from humans. It's common sense, and you want to know what impact it has. So we've looked at adversity, and this is the adversity measures we had. Poor marital functioning. We did not have sexual or physical abuse. Let's put it this way. It wasn't recorded. It probably existed, but we didn't have it. It wasn't in our records. So we used poor marital functioning, family discord, low family cohesion, parent-child discord, and divorce. Those are sort of standard ones. We found, as we expected, there was more adversity in the high-risk families. And of course, depression and other diagnoses were more prevalent in the offspring of the high-risk families. I've already shown you that. But we found that parental depression was the strongest predictor of major depression in the high-risk offspring. Why is that? Because the kinds of adversity kids have varies with the family. However, if you took parental diagnosis of depression, that captured it all. And there was no power left for any particular one. It was very different, of course, in the low-risk families, where adversity was the strongest predictor of major depression. And that's because their parents weren't depressed. However, the rates were much lower. And these results were consistent at year 2, 10, and 20. And they became stronger as the offspring aged because more people entered into the diagnostic groups. Oh, I think it was around the 10th year into this study, Lisa Miller came as a postdoc, and she was interested in religion. We say, well, we're ecumenical. If you think it's important and you can show it's a good risk factor, why not? So we added three risk factors for religion. How important to you is religion or spirituality? Is it highly important all the way to I'm not interested at all? How often do you attend church, synagogue, or other religious or spiritual services? The denomination we had anyway, and we also asked the denomination you were raised in, and we called R and S as religion or spirituality. And we put that into our wave 3, that was the 10-year wave. And we actually even got a grant when we published some of these findings. We went to pursue it. And we found that mothers for whom religion and spirituality was highly important were 81% less likely to have a depression than mothers for whom they said it wasn't important. We found no relationship to attendance. And denomination, the sample is primarily Catholic or Protestant. Very few Jews, there were no Muslims, and we had a few that said no religion. And they didn't fit into any of the groups. The offspring, the findings were similar. If the offspring reported that religion or spirituality was highly important, they had a 75% decrease in depression between years 10 and 20. And the effect was strongest in the high-risk offspring. Well, that's because they had more depression, so there was more power there. It wasn't for onset, but it was for recurrence. Again, religious attendance and denomination didn't predict any outcome. And there was an increase in depression, high importance of religion, and frequency of attendance over the 10 years. And this is the finding that we've just published last year and got a lot of attention. And that is, we were looking to see about parental religiosity and offspring suicidal behavior from 10 to 30 years. And suicidal behavior would be ideation or attempts. We found that parentals saying that religion was highly important was associated with a lower risk of suicidal behavior in both the boys and the girls. This was independent of parents' depression, divorce, parents' own suicidal ideation, and the offspring's own belief. Again, religious attendance had no effect. The effect was very strong. It's strong enough to have us published in JAMA Psychiatry. And none of us quite know what to do with this. And this is how we summarized it. We got a grant from the Templeton Foundation to do a survey of what does religious importance mean? I mean, that's one question, and you really get so much power out of one question. What is it capturing? So we did a detailed survey that was vetted by people who do this sort of research, particularly as a group at Duke in North Carolina. And we surveyed over 300 people, and we're analyzing the data, and we did factor analysis. It's a fairly long survey. Nothing else predicted the way that one question predicted. So we don't quite know what that one question is. I think it has to do with an internal ability to be hopeful and to also feel that you had important values. But I really don't know, and I don't think that our big survey is going to elucidate anything much. We also found that people who said that religion was highly important had thicker cortexes in the high-risk family. And that was published a few years ago by Ravi Bensal and Brad Peterson. Now, I'm just going to go through biological mechanisms just to show you that we know that that's important. And we have a whole group of people who are much more experienced and educated in this and have done, I think, very good work, particularly Jonathan Posner. It began with Brad Peterson, who's from Yale, and it was taken over when Brad left by Jonathan Posner and Adi Talate, who is trained in neuroscience, and Jürgen Kaiser, who does the EEG. But I'm just going to show you, so you can believe me, we do this work. This is actually the data we collect, and we're starting to collaborate with groups in Scotland and England to try to put some of these data together. Now, especially since the big GWAS have come out, and there's a paper circulating showing high PRS scores with familial depression. So we're trying to work together to put this into some kind of a collaborative, cooperative data set. By the way, we're now in wave 7. We're just beginning the second year of wave 7, which is 40 years. Now, what makes our study unique? Why would we want to bother to do this, other than the fact you can get funding to do MRI? But our study, I think, is unique because it allows us to distinguish between brain changes related to the risk of depression for the disorder from those that are a consequence. When you do MRI studies in people that are already depressed, you're not sure whether that may not be the result of the symptoms. We have people who we know are at high risk. We also have those who are at low risk. And we look at the MRI and other studies findings in those samples. So that's what makes, and also it's longitudinal, and we can see how stable the findings are, because if you have a biomarker that's not stable, it's not a great biomarker. These are things we did, and I'm only going to show you a little bit of it. I'll show you the structural. We wanted to look at the differences in cortical thickness between offspring at high and low familial risk for depression. And we found essentially that the offspring at high risk for depression had significantly thinner cortexes across the brain, the frontal, the occipital, the parietal cortices. These were trait rather than state markers, as they were observed even in the offspring who had never developed depression. And this work was published by Brad Peterson and PNAS in 2009, and we redid all of it in 2017. The reason we did is that between the time that Brad published he was a very inventive and brilliant man, but the field had changed and free surfer had come in. And Brad didn't have free surfer, so he used his own programs. And we felt that it was important for our study to be able to be compared with other studies. So we redid the whole thing using free surfer, and then we did the 8-year follow-up, which I'll show you. And we found that the results were pretty much the same. With free surfer, well, we didn't have the 30% decrease in cortical thinning with free surfer, but we had highly significant still. So I think the free surfer was maybe less good or maybe better. We don't know. But at least our findings were confirmed. We were very nervous about this one. So, as I said, you have to have clinical utility. You need a biomarker that's stable. And we had 82 participants who were scanned twice over 8 years. And we found that the findings were stable over the 8 years. And that was a paper published in John Crystal's new journal. We were, I think, one of the first ones to be published and has these findings. And these, for those who like MRI, shows you some of the findings. Well, I just summarized, we did resting state, and we showed the reduced ability to switch from rest to task-based networks, and that was work published by Jonathan Posner. And we're looking now at the stability of resting state. We don't think it's going to be quite as stable as structural because it's fMRI. We hope it's stable. This I'll just show you to give you an idea of where we're heading. We're not sure we're heading here. We don't know if we have enough power. But we have families where there's a lot of suicidal behavior. And this just shows you two of the families. I changed a little bit because these are New Haven families, and I wouldn't want any of you to think you know these families. But these are really what we found in two of these. We actually have some that are even larger than this. And these are families in which suicidal behavior, attempts, unnatural deaths, which are really suicide for the most part, and suicidal ideation is running through 3 generations. And we hope to get sequencing done and look at rare variants. That's the next step, as we're trying to hire a new geneticist at Columbia, if anybody wants a job. Well, let me just change to a different direction. Make sure I have enough time. Yes. We have to do something. You know, we've been studying this, and not to do anything, not to have an intervention doesn't seem to be quite right. And talking like an epidemiologist, depression in a parent is a modifiable risk factor. You're not going to change the parent, but you could change their depression. So one day, I got stuck at the airport in Maui with Maurizio Fava. And he told me all about STAR-D. And I said, STAR-D, that's a study with huge samples looking to see how you could prevent relapse in depressed patients. I said, that would be a great study to look at the children, to see if you increased remission and prevented relapse, do the kids get better? So we dreamed up a grant. The plane was delayed for many, many hours. We dreamed up a grant, came back, submitted it, and we got it. So we started a study in STAR-D looking at the children. And this was our rationale, that we wanted to see if the children would benefit from remission in their parents' depression, a modifiable risk factor. And these were the 2 people who were running the study, John Rush and Maurizio Fava. And what was across 14 sites, we took 7 sites because some of the sites were university sites and they didn't have enough kids. So, and besides, we couldn't handle 14 sites. And the purpose was to understand what to do next if the first treatment doesn't produce a remission. That would be in the mothers. And we blindly would be interviewing the children. This is how the study went. The mothers were treated for depression. The mother's outcome, that was totally separate from our group. And our group interviewed the children and followed them over time and looked at their outcomes. And I will just give you the bottom line, that if the mother remitted at the end of 3 months, the kids remitted. If the mothers didn't remit, the kids didn't remit. And there were a number of papers on this that essentially said the same thing, except what about the mothers who remitted later? And I've summarized that. That the child's improvement was significantly associated with the mother's remission status. If the mother remitted in the first 3 or 6 months, the early remitters, that was the most positive outcome. However, if the mother remitted after that period, the children still remitted, but at a lower level, and the child's clinical status was retained 1 year after the mother's remission. So we thought that was pretty good. We were very proud of these findings. We got a huge amount of criticism. this is observational. You can't say it's due to the treatment. It could be due to the fact the mother won the lottery. So we were sort of surprised because we were so proud of these findings. So we did another study. And it's true, without random assignment of treatment, you can't assume the child's improvement is related. But I don't think that matters. I still don't, because it doesn't really matter how the mother gets better. If the mother gets better, the kids get better. And there are many different things that can happen in one's life. It isn't just treatment. But the field was critical of us. So we did another study. And this is John Stewart from Columbia, who was leading the study, and Pierre Blair from the University of Ottawa, who was leading the Canadian part of the study. The mother's treatment by random assignment was citalopram, bupropion, or the combination. And the hypothesis was that the combination was going to way outperform the other two treatments. That was the literature. And that our kids would get much better if the mothers were on the combination. And it was 12 weeks of treatment. Didn't work out that way because the mothers got better regardless. The treatment didn't matter. They all got better or didn't get better. There wasn't a differential treatment effect. However, we found that the children of mothers who improved, they got better. And if the mother was on citalopram, there was much greater improvement in the children. And what we found from that study is bupropion on the Hamilton shows the same effect as the other treatments for the mother. However, it makes her very irritable. And we have other data, I didn't want to spend a lot of time on it, which we've published showing that the mothers were more irritable and the children reported it. And we haven't done more work on this, but it is something to think about if you have a mother who's depressed on a drug that produces the same symptom reduction, but perhaps more activation and more irritability, and she had small kids, it may not be the best thing. But we did show again in a randomized controlled clinical trial that if the mothers got better, the kids got better. And we were very pleased about that. So let me take the last part of what I want to talk about. We help the mothers, you help the child. That seems like common sense. And if you treat depressed mothers early and rigorously to remission, you can help even more. So what about pregnancy? What about postpartum depression? Our kids started when they were 6 years old, or most of them were 8 or later. So we started to think, when we started this study, we didn't even know how to interview the children. If it not for Kim Pujantik, who did the kitty SADs, we wouldn't have known what to do with the children and how to interview them. But how to assess infants would have been way beyond the realm of anything conceivable. So we've now started to think about pregnancy and depression. And we got involved in a study with Jay Gingrich on in utero exposure to SSRIs. Because remember, in our study of treating the mother and the children get better, the mothers were not getting psychotherapy. They were getting medication. So the issue is get the mothers better, whatever it takes. There was a study by Holly Schwartz in which she showed that treating the mothers with IPT had similar effects. But our studies were not psychotherapy. So, medication's a very good treatment. But then we got involved with Jay and his Conti Center and his work on in utero exposure to SSRIs. And what he found that exposure to SSRIs during sensitive developmental periods in rodents produces long-lasting effects on behavior and the neural circuitry in early adolescence. Well, how do you study that? You'd have to have a study in which you assessed the intake of SSRIs in pregnancy and follow the kids until they're 14 years old. That would be good to get funded. And this was Jay's argument that serotonin is highly conserved, and he suspected that we would see similar effects in humans. and because the SSRIs pass readily through the placenta and enter circulation, and that SSRIs are prescribed increasingly to pregnant women, and no study had followed the SSRI-exposed offspring beyond 6 years. In fact, I think there was only one study that even went that far, and all the data was equivocal, because these are observational studies. You can't randomly assign pregnant women to SSRI, not SSRI, and then follow their offspring. Actually, we're going to be doing that, but not with random assignment. I'll tell you about that. So, and this is where neuroscience and epidemiology have a great marriage. Birth cohort studies. Epidemiologists love this. They know about birth cohort studies. So we found one in Finland with huge samples, and we developed a collaboration with them. And they had over 15,000 who had SSRIs and psychiatric disorders, and 31,000 who were no SSRIs, no psychiatric disorders. And we set about using the birth cohort study to look at outcome in offspring birth to 14 years. Now, you can criticize this because, the diagnoses may not be as good as what you get. It certainly isn't as good as what you might get if you did a direct interview, but it's large samples, and we are moving in this direction now as we get into electronic health records, so it's something we're going to have to accommodate to and make good of. So this is what we found. Actually, we found exactly what we expected, that those offspring who were exposed to SSRIs had an increase of depression, and that increase occurred mainly around adolescence, and you can see there was an 8-fold increase by the time they were age 14. We had an SSRI discontinued group to try to control for severity, although it doesn't control that well. And these papers have been published. There was a series of them. We also found an increase in motor activity and language problems, and we saw that around age 10. That was work published by Alan Brown in JAMA Psychiatry. Now, this, you can imagine the criticism of these studies. They're observational. They could be due to the severity of depression, that if a mother, because depression itself in a pregnant woman has an effect. It could be that she's more severely depressed, and that's why her offspring has more depression when they grow up, and it could be that she was more depressed along the way. You could challenge it at every point. So what do? Well, we now have a study redoing the same thing in Denmark and at the Mayo Clinic. And they have somewhat different samples with different levels of diagnostic certainty. So we'll see. We can only replicate it. We can't go and do the clinical trial. But Adi Talati and Jonathan Posner just got funded to do the second study, which I think will be the definitive one. This is being done in Sherbrooke, Canada. And we're going to do MRIs on 375 infants at the time of birth and follow them over 2 years, having those who are exposed and those who are not exposed. Now, why are we going to Sherbrooke, Canada? Let me tell you, it's not easy to get to Sherbrooke, Canada. You have to go to Montreal and then take a van for 2 hours. MRIs cost $1,500 to $2,000 at Columbia. In Sherbrooke, they cost $300. They also have a very large fertile sample, and they also have health care. So you're getting people who have all levels of poverty or not poverty. They're all levels from society. So you're not just getting people who are very poor, and of course poverty has a lot of other problems for offspring. So this study is just about to start, and we're very excited. We think we may get a handle on this. But the climate is changing too. In 2017, the U.S. Preventive Task Force presented publications in JAMA in which they said that you should screen women who are pregnant for depression. And they said that medications have some effects, but it's not that much. And there aren't many psychotherapies. I think and this is all in the papers, so it's published, and I sort of give my opinion of the publication, but this is sort of what they said. Well, in February 2019, the U.S. Preventive Task Force came out with another report, and they released new recommendations. Again, they said physicians should screen pregnant women and new moms to identify those at risk for becoming depressed so they can be treated before they show symptoms. And guess what they recommended? Psychotherapy. One of the psychotherapies has been developed here. I mean, both are developed here, but Smith. I met Megan Smith. I met last night, who's developed the MOMS program, and that's essentially CBT, and that's is noted in the articles in JAMA. And we, of course, have IPT, and the work was not done by us. It was actually done by Nancy Grody out in California, Seattle. So for the first time, they're saying that psychotherapy may have an effect. Now, depression, not all women can be treated with psychotherapy. We know that there's severe recurrent depression, there's bipolar disorder, and the woman has to be given a choice. And that is a very difficult decision for a woman to make with her doctor. But a lot of the depressions are ones that can easily be handled and has been shown to be handled with psychotherapy, evidence-based psychotherapy. And it's wonderful that there's more than one psychotherapy, because you wouldn't want to have just Prozac. You want to have more, so that there's alternatives. For reasons you never understand, one works better in some people than in the other. This made the New York Times. We're very pleased. And I want to point out the situation, though, with psychotherapy. Great cartoon, isn't it? Psychotherapy in the United States has been declining. Mark Olson, who's in our division, has shown that in his reviews. And the training in evidence-based psychotherapy in psychiatry, psychology, and social work, actually most of it's done by social workers, is minimal. We've done a study of that. We actually interviewed training directors in these three disciplines, a probability sample. Research in poor countries through the WHO and the World Bank are making increasingly the availability of evidence-based psychotherapy. And my standard statement is, if we could bring what we are doing in Mozambique to New York City, it would be terrific. But we can't. And the paradox is what's being used in resource-poor countries is too expensive in the United States. Now, I don't want to sound like an ideologue. Not everyone with depression needs psychotherapy. There's time, there's medication. Medication is very good. I've actually done more clinical trials on medication than I have of psychotherapy. There's exercise, there's yoga, and there's at least, I think, 10 psychotherapies that have good evidence to them. And those can be helpful. There are some evidence-based psychotherapies. They can be administered by trained health workers in a triage model, and we need to train community health workers. I don't know about Yale New Haven, but we can't use community health workers. We train them in Mozambique, and we train them in Uganda. And in Uganda, we did a clinical trial that was published in JAMA. So it's 2 clinical trials, actually. And so it was considered to have scientific respectability. But we're not allowed to train and use community health workers unless, I guess, you go out of the medical system. That's too bad. So let me end with regrets. I wish our sample were much larger. I mean, we look now at samples in Bristol or some of the echo studies, and they're much larger than ours. Ours are very deeply phenotyped, probably more than we needed, but that's what it is. I wish we had started with pregnant mothers and included offspring from birth, but that's being done now with the echo study. It's a big multi-centered study. And to study 3 generations, it's much faster to begin with generation 2 that are maybe around age 40 and go up to generation 1 and down to generation 3. You don't have to wait 40 years to get your data. And I certainly would recommend that for anyone who wants to pursue this work. I believe this strongly, that if you want to understand the development of children and the clinical presentation of adults, you have to attend to the environment during preconception, in utero, and the family growing up. That's a lot to look at, but I think, and not everyone can do it all, but it all has an impact. And I think intergenerational research that begins as early as possible is a paradigm for this approach. And it's really a very interesting one for doing genetic studies or imaging studies or clinical studies and treatment studies. So what are we doing in the future? We are now in wave 6.5. That's the one that was funded by Templeton. We call it the 35-year. We try to understand what religion and spirituality is very important to me means. And we haven't, so far we're about 6 months into looking at the data, and I don't think we have any brilliant findings on this. We're doing wave 7. We're just entering our 2nd year of the 40 years, and we're curating our data. Remember, when we started this study here at Yale, they didn't have all the high tech for managing data. So we have a lot of records, It's just, it's impossible to get lost. So we are curating that, and that's a big job. We're interested in machine learning. We have somebody from Cornell who's going to be looking at our data with machine learning. We hope the machine is smarter than we are. We're doing RDocs because we were told we wouldn't get funded if we didn't. And I guess other people have had that experience. We're going to try, and actually, we do RDocs. We don't call it that. When we look in our imaging data, we look at things like rumination, and we look at cognitive functioning, and that's very similar to the idea of RDocs. We're going to try to follow up those suicide pedigrees, and we're not sure we have enough power, but we're going to try. And we've gotten intrigued recently by polygenic risk scores. We just were invited to be part of a grant looking at the use of polygenic risk scores with electronic medical records. And our group was invited as the epidemiologists, and we decided to agree to do it because we didn't know anything about it, and it would be a learning experience. And we spent 6 months. We've learned a lot. I have folders like this on electronic health records and psychiatry. We've actually submitted a paper on that because we couldn't find anyone who had written about all the things we learned in reading all of this stuff. And then we're trying to learn what polygenic risk scores are. I'm not quite sure I fully understand it, but it's an epidemiologist's dream. Because we have scores of social class. We can look at race, ethnicity. We could look at gender. We could look at parental bonding. These are all scores. A polygenic risk score gives us the risk for genetics. Now, those of you who are geneticists might say, what's going into that black box? And we're not sure, but we think it's worthwhile exploring, and there's more people doing that. It's based on the GWAS studies that have been done in hundreds of thousands of samples throughout the world. I think now I've given you an idea of what we mean by translational epidemiology. And there's a great quote here from Michael Rutter, who is one of my heroes. And the point he makes in this quote is that it isn't one way. It isn't just basic science to the bedside. It isn't just population to treatment. It goes in all different directions. And one of the most fun of this work is to work with people who are very skilled in things you don't know, but you know are very important to understanding what you want to learn. And that's something I learned at Yale, where it was very easy to do, and I've been fortunate to be able to continue it at Columbia. This is just one of our group meetings. We're a motley group of people. We meet every Monday at 11 o'clock, and we have more less students come and go. Thank God for the people who fund us. We hope they continue. And we always take donations. Thank you.